Hello everyone, thanks for coming back to our lectures. Today we'll be discussing Caesarean section, which is the delivery of the fetus after the age of viability through an incision on the abdominal and the uterine walls. So if you find a baby if you've got an abdominal pregnancy or a baby is delivered after uterine rupture, that is not a Caesarean section. And sometimes a hysterectomy is performed at the time of Caesarean delivery, and that is known as a Caesarean hysterectomy. If you do an operation in which you extract the baby before the age of viability at 27 weeks, 24 weeks, 25 weeks, at least here in our country, that is known as a hysterotomy. So there are different types of Caesarean sections. You've got the classical Caesarean sections and you've got the lower segment Caesarean section. The most common that we do, well, the most common worldwide for a very long time now, is the lower segment Caesarean section. As we can see in the diagram, the uterus has got a lower part, which is known as the lower segment, and the upper part, which is thick with muscle and is known as the upper segment. So a Caesarean section, when it is done in the lower part, it is known as a lower segment Caesarean section. Talking about the lower segment Caesarean section has got nothing to do with how the incision was made on the uterus. As you can see here, there is a transverse incision, and here you've got a vertical incision. Both of them were done in the lower segment. So whether it is a transverse incision or it is a vertical incision, it is still a lower segment Caesarean section. Here we've got a J incision. It usually happens, for example, in difficult Caesarean sections. You cut on the lower segment, but you fail to extract the baby. So then you go ahead and cut towards the upper segment so that you're able to extract the baby. This incision here is done entirely in the upper part of the uterus. This one is the classical Caesarean section. So once again, when we talk about the classical Caesarean section, we're talking about the incision that was made on the uterus in the upper part, on the upper part of the uterus. It's got nothing to do with the incision made on the skin. So if you find this, an incision on the skin that is vertical, that does not mean that it is a classical Caesarean section. Only if there is another incision that was made on the uterus and it disrupts the upper part of the uterus. This one is known as a T incision, an inverted T, so to say. There was a lower segment, incision, and there was an upper segment incision. This one is done also in difficult operations, like a transverse line. You cut, then you find that there's a hand, that becomes very difficult for you to deliver. Then you go ahead and extend the incision. If it is a transverse line, you will struggle. It is a very difficult delivery. And usually that is why people extend. And even with that, the outcomes are not optimal. So what is important here to know is that a lower segment Caesarean section, regardless of how the incision was made, is done in the lower segment. And an upper segment and the classical Caesarean section is when the incision is made on the upper part, of the uterus. So a Caesarean section has got indications, of course, that could be absolute or relative. CPD is an absolute indication because, if there is a CPD, the baby is not going to come out. If you've made a diagnosis of CPD, the baby is not going to come out. If there's a placenta covering the os completely, and that is known as a placenta previa, the baby is not going to come out. So now there are relative indications. These are many. Most of the cesarean sections that we do really are because of indications that are relative, like a previous cesarean section, fetal distress, labor dystocia, antepartum hemorrhage, a bad obstetric history, malpresentation. Yeah, those are relative indications. The indications can also be classified into category 1 or emergency cesarean section. This is when there's an immediate threat to the mother or the fetus in conditions such as an abruption, a cord prolapse. When you've got a rupture, you just have up to 30 minutes to save the baby, especially the baby. You just have up to 30 minutes. After that, you would have lost the baby. So that one is an emergency cesarean section. It should be done within 30 minutes. A category 2 or urgent cesarean section is when there is maternal and fetal compromise, but it is not life-threatening. This is a cesarean section that can wait up, 60 an hour or 75 minutes, between 60 and 75 minutes. So if you've got a CPD, you've made a diagnosis now, and she's just beginning to go into labor. So probably she can wait and you can do it 1 hour later. So that one is an urgent cesarean section. Then you've got a category 3 cesarean section where the mother needs early delivery, but currently there is no immediate risk to the mother or the baby or the fetus. For example, in IUGR, or maybe you've done an induction and it has failed, there may be no immediate need to take her for cesarean section. Then there's a category 4 or elective cesarean section. This is a cesarean section that is done at the convenience of the woman and of the health workers. There's another cesarean section that is one that is a cesarean section on maternal request. In this cesarean section, there isn't an obvious obstetric indication. And it's a difficult topic, a cesarean section on maternal request. It's one of the most controversial topics in our practice these days in modern day obstetrics. And it is becoming more common as women are becoming older. And as women become older, they become heavier in terms of weight. And the women are more educated. And because they are more educated, they know that they've got more options now for delivery. It's not only vaginal delivery. Women know that cesarean section is an option now for delivery. And they also seek more autonomy and more involvement in how they're going to deliver their baby. So all those factors add to the number of women that are requesting for the cesarean sections on maternal request. Now, these cesarean sections on maternal request should not be performed in women that in pregnancies that are less than 39 weeks gestation, because before that there is an increased risk of respiratory problems in the baby. And the current evidence does not recommend routine use of elective cesarean sections. But if you as a doctor, you've assessed your patient and you find that she's informed, she's well informed, she understands the risks and benefits of cesarean section and vaginal delivery, you may allow your patient to go ahead and have a cesarean section. But of course, you would need to, she would need to go individualized counseling on the risks and benefits of both a cesarean delivery and a vaginal delivery. And if a woman plans to have 3, 4, 5 children, or maybe 4, 5, 6 children, they may not want to have 4 or 5 cesarean sections because the risk there is higher. So for women that are going to have big families, a cesarean section, an elective cesarean section without an obvious obstetric indication may not be the best option. So what are the potential benefits of a planned cesarean section or an elective cesarean section? One of the most talked about benefits of a planned cesarean section or an elective cesarean section is a protection of the pelvic floor. With a cesarean section, there is reduced incidence of stool flutters and urine incontinence. There is also reduced incidence of pelvic organ prolapse. Then also a woman who elects to have a cesarean section avoids an emergency cesarean section. An emergency cesarean section is actually the worst type of cesarean section because this is a cesarean section that happens at 0-3 after you've done 2 or 3 already. So you're tired, you're fatigued, and you need to call someone from the lab, you need to call the anesthetist. So you are not, the preparation is not as it would be at 10 o'clock in the morning. So obviously the outcomes of the operations that you do in an emergency cesarean section are not as good as those of a planned cesarean section. Because in an emergency, maybe you tried a vacuum or you tried forceps, and so the head is down, impacted. The operation is difficult. You've got extensions of the cesarean section wound. There's so much bleeding. There's risk of you injuring the bladder, the ureters, the bowel. Almost all the bad things that can go wrong during a cesarean section happen during these emergency cesarean sections. Then also another benefit is that it has been noticed that women that choose a cesarean section and undergo a cesarean section are more satisfied with the process of birth because they feel that they've been involved in making the decision on how they're going to deliver their baby. There are benefits also for the baby of a planned cesarean section. Among the benefits is the reduced incidence of stillbirth and perinatal death rates. As you go beyond 39, 40, 41 weeks of gestation, the incidence of stillbirths and perinatal deaths increases. But it is believed that with a cesarean section, you could avoid the stillbirths and perinatal deaths. Also, there is reduced incidence of meconium aspiration after 39 weeks. And there is reduced incidence of the mother-to-baby transmission of infectious agents such as HIV, HPV, and the hepatitis. So there is also reduced risk of intracranial injuries that happen during labor. Obviously, if you do an elective cesarean section, you won't have to do a vacuum, you won't have to do a forceps. So the baby is protected from such injuries. Then there's also a better balancing between the healthcare providers and the clinical volume. You know, what this means is that the cesarean section is done at the convenience of both the mother and her doctors. So everything is ready. You've got your blood, you've got your consultant anesthetist, you've got your pediatrician. Everyone is well prepared for eventualities. So the outcomes are better with a planned cesarean section. So you get a better outcome for the baby. But of course, there are risks to the mother and there are risks to the baby. Among the risks to the mother is maternal death. Yeah, a lot of literature supports the risk of maternal death after, during or after a cesarean section. Much as this is an important complication that cannot be denied, it should also be mentioned that in the literature, most of the data combines the women that die from an emergency cesarean section and the women that die from a elective cesarean section. So like we mentioned earlier, the worst cesarean section is the emergency cesarean section. The outcomes for both the mother and the baby for emergency caesars are poor. So, however, the data is confounded. So it is difficult sometimes to separate how many women die from elective cesarean sections alone and emergency cesarean sections alone. You may even go to compare further with those that die from vaginal delivery, because often if a vaginal delivery fails, it ends up as an emergency cesarean section, and that mortality is counted as a mortality from an emergency cesarean section. But in reality, well, it started as a vaginal delivery that has failed. Uterine rupture is common, unfortunately, in our environment. So the risk of rupture in 1, 2, 3, 4 previous cesarean section is high. The risk of placenta previa. This is when the placenta, like we mentioned, covers the internal os completely or partially. The risk is increased in mothers that have had a previous cesarean section. Placenta accreta is when the placenta is like a worse form of placenta previa. The placenta now has embedded into the uterine muscle and it won't come out. The only way it can come out is by a hysterectomy. These conditions, placenta previa, placenta accreta, are associated with high morbidity and mortality because there's so much bleeding. So that is a huge risk on the mother. Other risks such as infections, hemorrhage, and injury to adjacent organs such as the ureter, bladder, bowel. These are injuries that can be associated with any form of surgery, and cesarean section is not exempt from that. The mother also has a risk of rehospitalization after she gives birth, and that rehospitalization is more common in cesarean section than in vaginal deliveries. Depression and negative feelings about childbirth are more common in women that have emergency cesarean sections, because women that have elective cesarean sections, women that choose to have cesarean sections, are often satisfied with the birth experience because they have what they want. They chose the cesarean section. the baby is at a risk of respiratory distress syndrome if the cesarean section is done before 39 weeks gestation. So this is very important. An elective cesarean section should not be done before 39 weeks gestation. Sometimes when you are doing a cesarean section, you can injure the baby, you can cut the baby. This is not very common, but it's a risk that has to be considered. When you give your spinal, the mother undergoes hypotension from the anesthesia. This may cause some form of transient fetal respiratory acidosis. Most women that have undergone cesarean section will have difficulties breastfeeding within a few hours of delivery. But after that, there isn't a long-term effect on the breastfeeding and the bonding. So, in conclusion, the cesarean section is the most common operation in the world. And women who request for the procedure must have as much information about the benefit and risks of both the cesarean section and vaginal delivery. So, thank you for listening, and I hope to see you on the next one.